Hello, everyone. Very nice seeing all of you today. And we are very happy to announce to launch our Pediatric Nephrology Fellowship Program. Today is our first webinar among a series of webinars we are going to conduct for the Pediatric Nephrology field. We have today great speakers. We have Dr. Louise Oni from University of Liverpool, and we have Professor Neveen Soliman from Cairo University. We also have great moderators, Professor Jameela Kari and Professor Khalid Elhasan from Saudi Arabia. And we have Professor Vandrea de Souza from Brazil. Here is the meeting agenda. I'm just going to give you a very brief introduction about the fellowship and the program. Then Dr. Louise Oni is going to give us the novel and traditional therapeutics for steroid unresponsive nephrotic syndrome. Dr. Vandrea is going to moderate the discussion with her. Then Professor Neveen is going to give us the up-to-date management and utility of genetic testing in steroid-resistant nephrotic syndrome. And Professor Khalid Elhasan is going to moderate the discussion with her. Then the closing remarks will be given by Professor Jameela Kari. Our fellowship program is wholly online, expected to start in January 2025. And as you can see here, we gathered an international great expertise in the field. We have Professor Ali Ashgar from Pakistan, Professor Elena from Amsterdam, Professor Hanan from Cairo University, Professor Jameela Kari from King Abdulaziz University, Professor Khalid Elhasan from King's Oud University, Saudi Arabia, Professor Neveen Soliman from Cairo University, Professor Rasha Samir from Mansoura University, Egypt, Professor Roxana Shroff from the University College of London, Professor Siddharth Kumar from India, Dr. Shigan Ersen from Cape Town, South Africa, and Professor Vandrea de Souza from Brazil. So as you can see, very nice diversity. We have representation from the whole entire globe. Why did we choose to do a fellowship in pediatric nephrology? This is because our children with kidney disease are vulnerable and they are very precious. And several circumstances, we have challenging cases we cannot solve in our own. And these children, if they cannot get the proper management and the precise treatment, they can have devastating long-term consequences. There is huge management gap in treating children with different kind of kidney disease. And in many occasions, there is inconsistency with no consensus in treating our patients. We need really to build up a panel of expertise in clinical pediatric nephrology field, especially in the developing countries. And this program is structured as 3 modules, 16 weeks each. It's a real education, not a webinar or seminar based, and it's built on dialogues rather than monologues. There will be question and answer, evaluation and assessments, tasks and assignments every week, and they're going to be a critical thinking and appraisal. And again, we are gathering a panel of international expertise in this program. It's a wholly online fellowship program. And every month we will have webinar, workshops, and video conferencing. Every week, the scientific materials will be released in a smart platform that all fellows will have credentials, will have access to. So they have the whole week to read and to study the scientific materials. They have the freedom to navigate for the educational contents throughout the whole week. So it's mainly based on asynchronized, not synchronized education because of the time constraint. So all fellows are supposed to turn in their tasks and assignments before the end of the week, and all activities and assignments are monitored in this smart platform. There will be weekly quantitative and qualitative assessment of the fellows' performance. The fellowship application closes November 30, 2024, and acceptance of notification will be sent through the email on December 15, 2024. Every month we will have another webinar. So we'll have induction meeting for the fellowship on Wednesday, November 20. Then we'll have orientation meeting on Wednesday, December 18, and onboarding meeting for the fellows who are going to join the fellowship on January 22nd, 2025. The program should start in January 2025. And upon completion of the program, the graduates should go up in their educational level from trainer and to a trainer and the mentor level, from trainees and mentees level. And they should be experts in the pediatric nephrology field. And they should also receive a graduation certificate from the American Association of Continuing Medical Education. There is a promo code for early birds. Those who are going to register before the end of this month are going to get 10% discount. And because we are a non-profit organization, we offer full scholarship to those who cannot afford the tuition fees from the low-income countries. So the countries in this color can apply and get free scholarship if they cannot afford the tuition fees. Again, the great aim of education is not knowledge, but action, and the knowledge itself has no value unless you put it in practice. So we are trying to stick to the clinical practice, and we will try to be very, clinically oriented, not theoretical, and all cases, clinical case scenarios, MCQs will be clinically applied. With that, I'm going to let Dr. Vandrea to introduce our first speaker today, Dr. Louise Oni.
Hello, everyone. It's a pleasure to introduce our first speaker, Dr. Louise Oni, who is Senior Lecturer in Pediatric Nephrology in the University of Liverpool. She is Associated Professor at UCL Center for Bladder and Kidney Health and Honorary Consultant Pediatric Nephrologist at Great Ormond Street Hospital for Children. Today, she will share insights on traditional versus novel therapies in the treatment of steroid unresponsive nephrotic syndrome. All of you can submit your questions in the chat, and they will be answered in the end. Please, Dr. Louise, you may begin your presentation.
Thank you. I'll just share my screen. Hopefully you can all see my screen adequately. So thank you to the organisers for inviting me to talk at this fantastic webinar today. As mentioned, I'm a clinical academic paediatric nephrologist in London in the United Kingdom and have an interest in inflammatory kidney diseases. So over the next kind of 15 minutes, we're going to talk about steroid unresponsive nephrotic syndrome and what's been titled Treating the Often Untreatable, with a focus on traditional and guideline-led therapies and then non-traditional and newer therapies that might be on the horizon. So, as I mentioned, I'm going to give a very brief overview of the immune-mediated nephrotic syndrome, but I'm really going to focus just over the short period of time on the treatments and then the future. Beyond the scope of this talk is genetic nephrotic syndrome, because my colleague will be presenting that shortly. And also I won't be covering complications, thrombosis, infection, which are all relatively commonly associated with nephrotic syndrome, but beyond the scope of this talk today. So I'm sure many people in this audience will know what nephrotic syndrome is, but just to start right back to the beginning, it's a classical kind of triad of the kidneys leaking excessive amounts of protein being found in the urine, and then clinical signs of edema. So typically these three aspects, and children will often present when they have quite significant edema because it hasn't been noticed beforehand, and that's usually how they will present to clinicians. So nephrotic syndrome is originally divided into kind of whether children respond to steroids or not. So there'll be a steroid sensitive or steroid resistant condition. But actually, as we're beginning to see that this is more of a spectrum where children can sometimes respond to steroids and evolve into steroid resistant disease, or they can have steroid resistant disease from the outset. And we know along that spectrum that there will be a proportion of children who have genetically proven nephrotic syndrome, and then a group of children who have this autoimmune mediated disease, which we've previously been calling a circulating factor. So something systemically is upsetting their immune system that's directly attacking the kidney and causing the clinical symptoms of nephrotic syndrome. And we also know histologically that there can be variation in the renal biopsy findings from minimal changes in the biopsy through to this classical features of focal segmental glomerulosclerosis. So what has previously been diagnosed as kind of two entities, steroid sensitive and steroid resistant, we're actually beginning to see as more of a spectrum of a disease. The International Pediatric Nephrology Association has published some fantastic guidelines which include definitions, and having a clear definition of the disease to allow you to diagnose the condition is really important. And these include the definition of nephrotic range proteinuria, which is dependent on the quantity of protein in the urine, usually measured through a urine protein to creatinine ratio or albumin to creatinine ratio, but can be measured using a urine dipstick. And we know that steroid sensitive disease is those that respond to a 4-week course of steroids from the point of diagnosis, and steroid resistant is usually those who have no response to 4 weeks of high dose steroids. We're beginning to see that there's a time period between 4 to 6 weeks, which IPNA called the confirmation period, where you may be able to try higher doses of steroids or alternative ways to get children into remission. And then there is complete and partial remission. We know that disease can have relapses, and there's definition for relapse. And in the recent guidelines, calcineurin inhibitor resistant nephrotic syndrome, and then multi-drug resistant nephrotic syndrome, which is what we'll be focusing on in this talk. So in terms of what's causing this, as I mentioned, I'm going to focus really just on the autoimmune aspects of this condition. And here we see a normal glomerular filtration basement membrane, and you can see the podocytes here attached to the basement membrane and endothelial cells on the kind of blood aspect of the kidney filtering barrier, and then the urine on this side. And what we see in nephrotic syndrome, when you look at these cells, specifically the podocyte, is that they get effaced, they get flattened, and they get diseased and damaged. And that leads to this leakage and proteinuria that's classical of this condition. And it can be quite dramatic and quite prompt when they do this, and lead to quite significant albuminuria. Histologically, I mentioned there are different features. The usual features are minimum change disease, where there can be very mild IgG staining and not very much histological changes, right through to big areas of focal segmental glomerulosclerosis, where we see damage and scarring, and that's usually reversible changes. So there's a spectrum of histological appearances that can be seen when children have a biopsy. Recently, there's been big shifts in this field, and I think it's a really exciting era that's probably likely to see significant changes over the coming years. And this is a really important paper here that's been in the New England Journal of Medicine, where autoantibodies targeting nephrin, which is a specific protein that forms the podocyte and keeps the podocyte shape and structure, has been found to be a key autoantibody in leading nephrotic syndrome that we previously didn't have a cause for. And if you look back, you can see that there have been smaller studies where they've looked at these autoantibodies that have targeted nephrin. And so this has been a conversation that's been evolving really over the last couple of years, but now seems to be moving nearer to clinical practice, where we might actually be able to measure some autoantibodies that might be able to correlate with the disease activity of nephrotic syndrome. IPNA also have, I've just cut this out of the guideline, but they have a whole extensive list of investigations recommended for when a patient first presents with nephrotic syndrome, and also how often these should be repeated, which are very helpful in trying to align our clinical care. They recommend screening for infection, and again, this is probably country specific according to what your local endemic infections might be and the risk of local infections to the child. And then I'm not going to touch on genetic testing, but the role of genetic testing and the use of the renal biopsy has been an area that's evolved over the last couple of years and is beginning to demonstrate strengths in trying to identify the differences between the autoimmune group and the genetically led nephrotic syndrome. So just to move on to treatments, I mentioned the IPNA guidelines. These are something really worth reading if anybody wants to know more about the condition, about how to manage it. These are our best practice literature-based guidelines. But what it's worth pointing out is that the evidence in this area is fairly limited. And actually, when the evidence is great, most of it's of relatively weak or low recommended strength. So it's something it's a starting point for building future evidence, but it's worth bearing in mind that there are often cases that might not fit into these traditional frameworks. And actually, when you look at the literature behind it, it can often be fairly limited. So the first line immunosuppressive treatment for children is the use of steroids. If they're then steroid resistant, which is what we're going to focus on, all children should be recommended to be treated with ACE inhibitors when they're stable enough to do so and they're not sufficiently, they're appropriately fluid replete. The first line immunosuppressive treatment in cases of steroid resistant disease is calcineurin inhibitors, so either cyclosporine or tacrolimus, and these have been shown to have the highest rate of achieving complete remission in children who haven't responded to steroids. They then suggest weaning the doses of steroids over the subsequent 6 months with the aim to get children off steroids if they haven't demonstrated any response. Within the paper is a really nice layout of the treatment, starting with whether they respond to steroids or not. And if they don't respond to steroids, as we mentioned, is the focus. They then go on to have renin-angiotensin system inhibition, consideration of genetic and biopsy information. And they will then be classified as to whether they have a non-genetic steroid resistant nephrotic syndrome, in which case I mentioned the calcineurin inhibitors would be your first line treatment. And over the first 6 months, you would then evaluate whether they've achieved any remission from calcineurin inhibitors. And if they do achieve remission, you would continue that therapy and try and minimize the dose if they've been on it for a significant period of time and consider adding in other agents to help reduce the amount of toxicity that the drug might be having. If they've achieved a partial remission, you might consider continuing it, and you may then consider adding in another agent such as mycophenolate. Or if they've not achieved any remission, then you would call them calcineurin resistant nephrotic syndrome, and you would consider stopping the calcineurin inhibitor, thinking about whether there's any clinical trial options and considering B-cell depletion in these patients if available. If they then haven't achieved remission despite another agent, this is the group where we would call them multi-drug resistant, steroid resistant nephrotic syndrome. And these are the really high risk patients of progressing to end-stage kidney failure and going on to potentially being at risk of relapse after having a kidney transplant. And these are the small groups of patients who are the highest risk, where we may consider treatment that hasn't really got significant evidence behind it and might be more experimental. So I mentioned that some of these papers, some of the evidence supporting this is based on relatively small studies. There is a study here that demonstrated about 40% complete response in patients who have steroid-resistant nephrotic syndrome, which is idiopathic, so not genetically proven. What you can see and what is consistently reported is about 40% of the children will respond to calcineurin inhibitors. We also see in other studies that this was a slightly bigger longitudinal observational cohort study, and they looked at children with steroid-resistant nephrotic syndrome and compared intravenous cyclophosphamide with the calcineurin inhibitors and found that there was no difference. And each treatment had this similar response rate of achieving about 40% remission. So there doesn't seem to be any advantage over intravenous cyclophosphamide in this group of patients. This was another paper looking at comparing mycophenolate versus cyclosporin after having B-cell depletion for steroid-resistant nephrotic syndrome in a maintenance phase, and they found that MMF was superior. So if you go on to treat somebody with a B-cell depletion, it might be that MMF is a superior kind of maintenance agent to use rather than cyclosporin. And this was another paper that looked at a multi-center trial comparing rituximab with steroids and then in addition to cyclosporin, and this was just a single arm study, and what they found was a really good response rate, but again this was only 6 children who were recruited to this study. So really great different ways to add on therapy from a fairly limited number of immunosuppressive agents, all of which are relatively broad spectrum, but attempting to try and reduce and minimize the amount of proteinuria essentially, and ultimately achieving complete remission. Additional considerations is the repeat kidney biopsy has a role. If you've been on calcineurin inhibitors for more than 2 or 3 years, then it's sensible to try and look for nephrotoxicity if possible. As I mentioned, it's helpful to try and wean and then aim to stop the steroids over a 6-month period if they haven't had any effect. And then we would suggest using MMF rather than a calcineurin inhibitor if the child had a low renal function and still needed immunosuppressive agents. So if it seemed like there was any reversible activity in their kidney, then a nephrotoxic agent such as a CNI might not be suitable in this setting. We've talked about the additional role of MMF, and it may have a secondary role if there is a partial response or if there's toxicity related to the drug or a long period of time on the drug. It might be that MMF has a role in supporting a reduced use of calcineurin inhibitors or acting as additional immunosuppressive agents. And if there's complete remission with a CNI for 12 months, then you could consider weaning the CNI and seeing whether the remission is sustained clinically. Like many kidney diseases, we would suggest low salt intake. You can manipulate the fluid intake, especially if they're edematous at the time. Sometimes need to use diuretics to manage their edema, and then albumin infusions if there's refractory edema, and perhaps also if there's symptomatic hypovolemia, so concerns about acute kidney injury due to low volume intravascular volume, then you might have a need for more urgent albumin infusions, and the ITMA guidelines suggest how and when to use these safely. So just to move on then to non-traditional treatments in this kind of whistle-top show of what we do in steroid-resistant nephrotic syndrome. There are now a number of trials coming through looking at multi-drug resistant nephrotic syndrome. So this is the small group of patients who haven't responded to steroids, haven't responded to calcineurin inhibitors, and haven't responded to additional attempts such as rituximab or MMF as adjuncts. And these trials are in the on clinicaltrials.gov, showing that different ways to try and attack the B-cell line may be an important way to try and reduce the amount of proteinuria or achieve complete remission in this group of patients. And so, for example, there are these trials open at present, and many of these drugs have been derived from cancer studies, so lymphoma type studies where they've tried to reduce the lymphocyte activity. And then also CAR T cells, which have been evaluated in other inflammatory conditions such as lupus. There's a study at the minute looking at CAR T cells and whether they have a role in this small group of patients at very high risk of organ failure. Additional methods might be plasma exchange, and this is used particularly in post-transplant recurrence of nephrotic syndrome, which is beyond the scope of today, but most patients would receive plasma exchange if the disease recurred very acutely and severely. And likewise, the liposorber, which is to remove lipids through lipid apheresis, may have a role in this multi-drug resistant nephrotic syndrome in trying to remove the lipid component to then allow patients to achieve the steroid sensitivity again. So these are a very small group of complex patients and very difficult to evaluate in clinical trial settings. So it's fantastic to see some evidence may be generated in this area, which would be brilliant. But I think the future is where things are really exciting, and I think this is probably one of the last slides. As I mentioned, the anti-nephrin antibodies are hopefully going to then open up the opportunity for more specific antibody-directed targeting that would lead us to be able to monitor the disease activity by measuring anti-nephrin antibodies and seeing that there may be patients at risk of relapse before clinical signs of relapse, and then more specific drugs that are able to just act on this antibody rather than having to deplete their entire immune system in a very broad spectrum way, such as through the use of steroids, which have side effects. So I think we're in an exciting era at the minute. We hopefully will see change over the next few years in the way that we manage and treat childhood nephrotic syndrome. I think that this would hopefully reduce some of the side effects that we see with steroids, but I think there are concerns remaining. This group with multi-drug resistant disease have a very complex course and often need to be captured and managed fairly early. Hopefully the treatments will work for that group of patients as well. We still have concerns about drug side effects and any new drugs or biologic agents. We really don't know the long-term side effect profile. And then one concern that I think is particularly relevant when doing global talks is the inequalities facing patients across the world when some of these treatments really aren't accessible, and we may then widen the inequalities, which we really don't want to see for children with kidney disease. So I think that's everything. I'd like to thank you for having me today. Really happy to answer any questions, and hopefully gave a really brief overview of how we manage steroid-resistant nephrotic syndrome. But please do look at the IPNA guidelines for much more detail, because they are really quite a fantastic resource for our global community. Thanks.
Thank you very much, Dr. Louise, for your presentation. Excellent presentation. And we have some questions. What's the role of SGLT2 and the treatment of those cases? Have you any experience with it?
No, I'm aware there's small cohort studies where they've looked at this, and we know in adults who have chronic kidney disease and proteinuria that there is evidence to show that the SGLT2 will delay the progression to chronic kidney disease stage 5. I suspect in children with glomerular diseases it's similar, and what we don't know is the safety of these drugs in the younger populations, but there are clinical trials coming. So I think in the patients who have chronic kidney disease associated with proteinuria and they're in the more chronic phase of the disease, there's likely to be a role similar to the adults. I think in the acute phase they're probably not likely to have a huge immune mediating role to manage some of these conditions, but I think in the chronic disease they would potentially be a great adjunct to the renin-angiotensin inhibition, and hopefully the evidence will come in the next couple of years to allow that treatment to come to children as well as adults.
Okay, and we have another, thank you very much. We have another question. In unresponsive nephrotic syndrome, usually we'd have a consensus on what level of calcineurin inhibitors to target initially.
Mm-hmm. Yeah, so again, I refer you to the IPNA guidelines because they're fantastic. They've even got what levels to do, when to monitor them, what thresholds to aim for. So the level of detail really is in the guidelines. And usually as a starting point, you would aim for a level, a tacrolimus level of around about 5 or 6. But this may be personalized according to whether they get toxicity, and you might want to run it slightly lower if they're in remission, and equally if they had difficult disease you might want to run it slightly higher. But again, in the IPNA guidelines, those thresholds, those monitoring levels and the dose that you would start are all within the guideline. There's a lot of detail in there.
Okay, thank you very much. Another question, is MMF preferred in maintenance after rituximab or not?
The small amount of data suggests that it may be beneficial. Having said that, some children will go into remission just with rituximab alone, and there are a group of children who will be having rituximab because of poor compliance, probably with oral medication. So I think, again, some of these cases come down to individual cases and, you know, patient preference. I think that there probably is a role in supporting immunosuppression in the longer term for when the rituximab B cells repopulate. And that's what's suggested in that paper, that there may be an advantage. But again, I think there are some children who just need the rituximab and they don't need any other treatment, and we don't really have any way previously to monitor this. Hopefully when we have antibodies, we'll be able to see if actually when the antibodies recur and whether we need additional agents to keep the antibodies away. But at the minute, it's very much clinically based, and that can be very difficult without a biomarker to be able to monitor the disease.
Thank you. And considering rituximab, what is the youngest age at which you use rituximab for children?
I think usually most children will be presenting, the younger ones will be presenting as toddlers, you know, 2-year-olds, whatever. By the time they get to having had the steroids and gone through a few of the treatments, they're usually in that preschool age. I think that there isn't really an age threshold where you would say that they are have to meet a certain age threshold. But I think in a, you know, in an infant, it would be unusual to do it. I think in a toddler, it would be acceptable. But I think in reality, most children are in, you know, school years really, because by the time they've had some treatment and you've seen that they're running a slightly more difficult course, that's when they usually get to rituximab. So at the minute, I think it's usually children around the school years, but I don't think there would be hesitation in the younger ones. But I think it would be extremely unusual in an infant when actually most of those are the congenital genetic based nephrotic syndrome. So that's a rough guide.
Vandria, if you allow me to comment on this, so
Okay.
I think probably the one who asked, he's worried about the a probable side effect of rituximab, what's the one which we usually worried about, which is the hypogammaglobulinemia. And there's a couple of reports that being in those less than 6 years, probably the risk is more than those more than 6 years. That's the only, probably the concerns. Otherwise,
Yeah.
I totally agree with Louise.
Yeah, I think hypogammaglobulinemia is a risk. It's real, it's there, even the adults see it. I think it comes with the repeated doses, it comes with patients who have a low IgG beforehand, and there are some kind of risk features that might allow you to identify patients. I think with single doses, the risk is relatively low and acceptable. I think it's the children who have multiple doses where you really do have to weigh up whether it's worth the risk of them then needing replacement immunoglobulin that could be lifelong. So I think it's something to consider, and it's definitely something that's real in there. And we may see more and more of this as we start to get more specific targeted treatment that children might need over a long period of time. We're going to start to see some of these side effects that we have to balance up then whether they're worse than the disease or worse than the other treatment options that we have, and how we then can stagger and use the resources that we've got. So yeah.
Okay, thank you. And another question is, there is any role in giving rituximab while patient is having evidence of B-cell depletion, but signs of relapse?
I usually wouldn't, because I would assume then that it hasn't necessarily worked, and it could be other parts of the immune system that are active, and I would therefore try and use other immunosuppressive agents. I think more and more there's bits of evidence and cohort studies coming through to suggest some of the other B-cell depleting agents like obinutuzumab or something might have a deeper B-cell depletion that you could then use, or even belimumab with rituximab possibly, to get a deeper B-cell depletion if you're not getting the full effect from rituximab. But I think if your rituximab has depleted your B cells and you've then got a clinical relapse, I probably wouldn't repeat the dose unless it was a significant period out and there had been some repopulation. But I think if you had, still had B-cell depletion, you were 6 months after dose and they had a relapse, I probably wouldn't repeat it. I'd think of a different agent or adding in an alternative B-cell agent if possible. And some of those drugs are really just on the horizon, particularly in pediatrics.
Thank you again. And I think that we have time just for one more question. Do you suggest using lipid-lowering agents in resistant nephrotic who do not respond to calcineurin inhibitors or not?
Again, there's no evidence to support what we do in lipid lowering in children at all. It feels like the right thing to do. And I think in the slightly older children, where we know that some of the medicines to lower the lipids are safe, I think it's often done in as good practice because we feel it's the right thing to do. I don't know if we have any evidence that that improves their long-term cardiovascular health. And I think overall the aim is to try and switch the disease off. But I think once you get to the point where that's not realistic, then these additional management strategies like blood pressure control, lipid control, and everything are surely going to help. But again, we just don't have the evidence to suggest that these drugs are effective and what the long-term benefits might be. And that's probably because the children often then progress to end-stage kidney disease, and you then have chronic kidney disease and everything else mixed in that it's very hard to evaluate. But I think it feels the right thing to do to give them lipid therapy once they get into long-term treatment. But yeah, it's not based on any substantial evidence.
Thank you very much, Dr. Louise. Excellent.
Thank you.
So thank you very much for Louise and Valerie for wonderful and very enlightening and terrific talks of the initial part of this webinar. So we'll move on now to the second part of this webinar. And before I will start this, I would like to thank the World Kidney Academy of entering the pediatric nephrology parts, which is probably the first scientific talk in pediatric nephrology from World Kidney Academy, and hopefully that will be continued. And we'll hope also the fellowship that's been already introduced by Dr. Amr El-Husseini, and would like to ask all the colleagues whose enthusiasm to join this fellowship and this excellent educational online. So without further delay, it would be my great honors actually to introduce the second speaker, who's very well known, especially in the Middle East area and in Arab worlds, Professor Neveen Soliman, she's a professor of pediatric nephrology and of pediatrics at the Cairo University. She was actually the vice dean for the research and postgraduate affairs in the same university. And she's currently the chair of the scientific committee of the Egypt Genome Project. Also, she's the editor-in-chief of the Journal of the Rare Disease. And she's the founder of the special group for that, the orphan renal disease. So she will give us overview about the genetics parts of this, sometimes I can say a difficult disease that can be faced by general pediatrician or even the pediatric nephrologist. So the floor is yours, Neveen, so welcome.
Thank you very much, Dr. Khalid, for this introduction, and I thank the World Kidney Academy for giving me the chance to meet you guys in this very first pediatric nephrology webinar of the World Kidney Academy. We'll be talking about the genetic testing, the part that Louise in her fantastic talk before me said it's out of her scope. Now it's the scope of this talk is to talk when to do genetic testing for our patients and why to do it. I have no disclosures. And this is the outline that we'll try to go through, and we'll end with real life case scenarios that we'll go through. I won't go through the definitions, but I wanted to focus on the definition of nephrotic syndrome, nephrotic range proteinuria, and nephrotic range proteinuria in children should be standardized, whether protein creatinine ratio is standardized to creatinine or to the surface area. So it has to be standardized, it's unmarked in adults. And this is the definition of steroid resistant that Louise pointed out earlier. And this is again this is an interesting paper in Nature Reviews of Nephrology by Salim, where he was having this nephrotic syndrome. This is the part, nephrotic syndrome idiopathic, weather sensitive, which is not the focus of this webinar, but we're talking about cirrhosis. And I had this red frame so as to say that there is a primary steroid resistance, secondary steroid resistance. We don't have to forget about these. These are patients who were initially steroid sensitive and they turn to be resistant later, and the ones presumed steroid resistant. They don't get steroids, but we presumably they are steroid resistant because they are genetic in the first year of life or familial syndromic. Again, this is the one that we did earlier, just to see that there are 4 weeks of steroid response, a confirmation period of 4 to 6 weeks before declaring the patient steroid resistant. And then we have to look who is of genetic origin, the monogenic SRNS, and who is not. So again, this is the kidney, and this is the filtering part. If you, this is the glomerulus, and if you focus on the glomerular capillary, this is the glomerular capillary. These are the endothelium. This is the blood side, and this is the basement membrane. These are the podocytes. And the podocytes have, interestingly, food processes that interdigitate in such a unique way, and to have ultrastructure. And what's the relation of genes to the glomerular basement membrane and the leak of proteins is that we can find here that the nephrin acts. These are the podocytes, and this is the skeleton of the podocytes, which is kept by the function of proteins of these genes here. And the nephrin plays an important role because it's like a zip-like structure. When it's tied, proteins cannot pass. When there's a problem in the nephrin gene, then there's a problem in leak and filtration of proteinuria. And the two genes here, the podocin and CD2AP, these are the genes that connect the cytoskeleton here of the podocyte to the zip-like structure of the nephrin. So this is what keeps the glomerular basement membrane intact. As you can see here, there are a lot of genetic variations, and we now resort to the term variant and not mutation because it dictates, it's according to American College of Medical Genetics guidelines lately. So these variations are, these are the genes, each produce proteins that are involved in steroid resistant, monogenic steroid resistant nephrotic syndrome. So a lot of genes, over 60, and they are either in the cytoskeleton, the podocyte, or in the glomerular basement membrane. If you look closely here, you will find LAMP beta-2 gene and the collagen genes of Alport syndrome are in the glomerular basement membrane. And this is an interesting figure where we'll see that the variants in the podocyte genes, they decrease with age. So monogenic steroid resistant nephrotic syndrome is inversely related to the age of onset. So you find most of the ones with infantile nephrotic syndrome in the first year of life, as we'll see later, are mostly genetic, and then the percentage decreases as we go up in age. So how do we deal with our patients? So I have to have a patient with approach, so I can have a decision as to have a genetic testing for these patients. First of all, it's the history and the family history that sometimes we overlook in the busy clinical practice. The family history is extreme importance, and the physical examination. Don't forget not just to examine the kidney, go beyond the kidney. Look at the names for nail dysplasia, patella, for the genitalia, for the eyes, neurological. This is how you pick up cases that are not isolated steroid resistant nephrotic syndrome and probably are familial or syndromic. And nephrotic syndrome, as you all know, it's the edema, the nephrotic range, proteinuria, hyperalbuminemia, and the hyperlipidemia. And familial clustering is essential to diagnose familial SRNS, which denotes a genetic base. So we have to have a family history that falls into most of the genetic steroid resistant nephrotic syndrome are either autosomal recessive mostly, but some are X-linked and autosomal dominant. And we look into X-renal involvement. If you can look here, This is an X-ray where there's an absent patella because the clinician suspected that there is no patella in this child. This is another one with microchoria, small pupil that is not responsive to light, one with sensorineural hearing deafness and so on. So the indications of genetic testing in CKD in general, this includes SRNS, are first and foremost is that either there's a family history or exrenal involvement, but the young age as well is an important factor or unusual disease course. And now the undetermined CKD is focused in many studies now, whether pediatric or adults, a focus of unraveling the genetic basis, if any, in these categories. So what we do as clinicians, we deeply phenotype our patients, whether it's clinical, laboratory, pathology, imaging. So what about genomics? With genomics, we integrate genomic information into our clinical care. It's no more research-based. It's now used on clinical basis for the management. But all nephrologists are faced with this uncertainty. Whom to test? Now we have a clue as to whom to test. Which test should I select and what to expect from the test? And with the rapidly advancing high throughput technology and next generation, people get confused as to what should I ask for and how to interpret. So monogenic SRNS, are they underestimated, overlooked, or misdiagnosed? Yes, in many parts of the world, they are still. So we need to know, and that awareness should tackle this, and that's what we are doing here in this webinar, and look for it. You cannot find something that you, unless you look for it, and you don't look for it unless you know it. So this is why we're doing, and this helps in the diagnosis and treatment for our patients. So genetic testing, why do we do it? Because it helps in diagnostic classification of these patients, prognostic assessment, therapeutic approaches. This is on the clinical part, but as well as on the non-clinical part, it helps to provide us with insights as to pathways of monogenic SRNS. So it's both clinical and research-based. And these are the indications, as we said before. We won't go through them, but don't forget about secondary steroid resistance. And most of the patients are in the first 3 decades of life, unless there is a strong indication afterwards, but it's usually infants, children, and young adults. And how we do it, we usually do it through 2 tests, whether gene panels, where we get a panel of genes that were reported to cause monogenic SRNS, and we test for them, and then the whole exome sequence. So what's the difference between them? Is that in the panel, we look for certain genes. So in the genome, there are parts that are coding for proteins that cause disease, and parts of the genome are non-coding. So here I look for certain genes. So if I don't find the patient affected with any of genes that were reported so far to cause monogenic SRNS, means these genes are not responsible for his disease, but doesn't mean he's not monogenic. To know if he's monogenic or not, I have to look through the whole coding region of the genome, what we call the whole exome sequence, which is about 2% of the genome. But in more difficult cases or on research base, we go for the whole genome sequence. So on clinical basis, it's either the targeted panels or the whole exome sequence. With the targeted panel, bear in mind that you will miss novel genes that are reported by the day. Okay. So there's a Mendelian surprise here in nephrotic syndrome, yes. And this is to show you the difference between back then in 2010, where this is a wonderful classification of familial nephrotic syndrome and associated syndromes, like Dennis-Drash that you see, or familial like Dennis-Drash, associated syndromes like Pearson. See number of genes here. And this is another one that was reported a decade later. See the number of genes that we are having. So they continue to increase by the day when more population are studied, particularly areas with higher consanguinity. And this is the work that's been done by Hildebrand and his group in Boston. And when they looked into more than 1,500 steroid-resistant nephrotic syndrome in the first 3 decades of life, and they managed to solve 25%. These are the shades in blue. The ones in orange are phenocopies, and phenocopies, that means that the patient came as steroid resistant, but the main disease wasn't steroid resistant. For example, cystinosis presenting with SRNS. And these are the novels that still have to be validated. This paper, they solved 25% of the cases, and this shows the distribution of the genes or phenocopies, and the gray ones are the negative. So a timely genetic test can provide you with diagnosis for the patient and family and this odyssey and long treatment journey, hard treatment journey, and you reduce unnecessary damage, whether by kidney biopsy or by treatments, arsenals of immunosuppressants that would render your patient immunocompromised or increase the blood pressure, and uncover a form of SRNS that's amenable to treatment, and we will see that later. So this is what we call precision medicine, enabling genomic-driven healthcare, and we can do it. If you look at this global total consanguinity rates in the world, you see most of the literature coming from European and North American and Japan, but a little is coming from this area with the higher consanguinity where you expect autosomal recessive diseases are common. So we don't know. And that's why in many of the publications, they say in this area, steroid-resistant nephrotic syndrome is higher compared to other areas, and probably due to higher prevalence of genetic nephrotic syndrome. The group in Boston as well did work that a decade ago when they looked into a worldwide cohort of steroid-resistant nephrotic syndrome and see the percentages of monogenic SRNS among the patients. If you look, this is America in 13, 14, Europe 20s, and if you look at India, almost 20s. But look at this, this is very startling. Almost 45% in Egypt and Saudi Arabia, which falls within the high consanguinity zone. And this is because it increases with consanguinity, and consanguinity in these parts of the world plus 40%. And if you look at the genetic yield in these patients, if you look here, you will find the genetic yield in the first year of life higher, and then it declines as we go up in age, and this is expected. So monogenic steroid-resistant nephrotic syndrome will eventually pass into end-stage renal disease, and that's the bad news. But the good news is that recurrence in the transplant is far less than the non-genetic. And you can see here that they usually pass, these are the genetic, they pass, but the recurrence of the transplant is far less than the other non-genetic. So the clinical implications of kidney genomics and SRNS is either it will identify genetic subtype. I know that this patient had MPHS2 variant, the Podocin, so I avoid intensive immunosuppression. I look into preparing for safe renal replacement and donor selection because the parents will be heterozygous, the patient's homozygous, because this is autosomal recessive and the parents are heterozygous, and you should counsel the parents about this, or it could reclassify the diagnosis because the patient is presenting with SRNS while actually is having a collagen variant of 485. So he's actually an Alport syndrome with not necessarily, it's unnecessary to give him immunosuppression with renal protection, and there's a window for novel therapeutics that's beyond the scope of this talk. So actionable genes in kidney diseases means that I discover gene and it has an action in the patient management and counseling the family and prevention. Like here, if I find a CoQ10 genes, this means it's amenable to therapy. Or if I find this is Alport, so this changes the treatment strategy, and I avoid lung immunosuppression given these genes, and it truly helps in counseling the family and for pre-symptomatic diagnosis and antenatal and pre-implantation diagnosis. So it's now a diagnostic pillar in the clinical practice for early diagnosis, more precise, that you can build informed decision as regards treatment strategies or transplantation strategies, donor selection, and so on, prognostic factors given to the parents. And now we'll go to the real life cases. These are real life cases. A 3-year-old male child with SRNS, onset at 18 months with childhood, kidney biopsy, FSGS by light microscopy. What next? There are two scenarios for this child he would go through. The usual scenario where he gets immunosuppression and then we intensify immunosuppression and change. So we'll have arsenals of immunosuppressions until we declare him. We cannot do anything with this child after he got through all the adverse effects of immunosuppression. Or there's another scenario. I said this is an early nephropathy. We tried steroids. And then why don't we look for genetic cause for this? So exome sequencing revealed homozygous pathogenic variant, CoQ2 gene causative, causing the steroid-resistant nephrotic syndrome of this child. And what are the implications of these? These are the implications. On the treatment, patients will be amenable to therapy giving CoQ10 supplementation will resolve this proteinuria, and I have to look if he is passing into end-stage renal disease, what are genetic testing for potential family donors to select safe donor, particularly in areas with no access to disease transplantation. I can predict the extrarenal involvement because I know there will be an element of neurological involvement, cascade screening, pre-symptomatic to the siblings, and reproductive counseling should the family need to have another child by pre-implantation genetic diagnosis. So this is case 1, going to be amenable to therapy. Case 2, a 9-month-old female infant, non-consanguineous parents, nephrotic syndrome at the age of 7. So this is nephrotic syndrome in the first year of life. No apparent extrarenal manifestations whatsoever. And the kidney biopsy at 8 months was FSGS, 80% locally sclerosed lumps. So what next? Some would try further immunosuppression, even though this is not the case in the first year of life. But the best thing is to go for genetic analysis, and exome sequencing in this child revealed heterozygous variant, pathogenic variant in Wilms tumor suppressor gene. And if you do a karyotyping for this child, she's actually a male, she's 46X1. So she's actually a male with straight gonads intra-abdominal. So what are the implications? First of all, sex assignment counseling with the people responsible for the transplantation strategy, because she will pass into end-stage renal disease. So I should start putting proper strategy and selecting the donor. And I predict the extrarenal involvement because these children with WT1 variants are liable to develop Wilms tumor. So there is a follow-up for these patients to be able to detect early. But for the gonads that are usually intra-abdominal, they are straight gonads, so it's better to take them out to avoid the gonadoblastoma. And again, the cascade screening and reproductive counseling. And in case 3, and that's the last case, a 15-year-old female, an adolescent of consanguineous parents, nephrotic syndrome at 12 years, no apparent extrarenal manifestations. Kidney biopsy at the age of 14 years was FSGS with effacement of food processes. So what next to do? She had immunosuppression after immunosuppression, and then at the age of 18 years, they decided to do another kidney biopsy to know what's going on, only to discover that there was glomerular basement membrane splitting and annihilation by EM. And exome sequencing revealed homozygous pathogenic variant in COL4A3 gene, one of the collagen genes. So this is actually an Alport syndrome presenting as SRNS. What do we get from that? That the pathological diagnosis of Alport syndrome is not always there early because she was first biopsied at 14 years. And there was no extrarenal manifestations because they develop at certain ages. So they might develop later down the course. So if I'm having, particularly pediatric nephrologists, they won't have the full-blown picture of Alport syndrome with all the extrarenal manifestations, but it should be considered with high index of suspicion. So this one was a delayed diagnosis for such a child. We avoid parents as potential donors. we start to follow up with the treatment with the ocular, and again, the cascade screening and the reproductive cancer. And I get here to in my last couple of slides, the key messages. Monogenic SRNS is frequently overlooked, and there's significant phenotypic heterogeneity, as you have seen, so we have to look closely into it, and knowing the merits of the genetic testing we are doing, that they will inform our decision, as you have seen in the real life cases, will change the management. The variation, the spodicide-associated proteins are responsible for 30% of SRNS in childhood, but again, this is a collective number because they might go higher in some areas with higher consanguinity, and they depend upon the age of presentation. Because it's inversely related to the age of onset, and this will allow us to have more personalized treatment approach in these patients, in addition to more research to understand what's lying beneath, so we can so it can be reflected on clinical healthcare of these patients. And again, the molecular diagnosis of SRNS not only goes on the medical line, but it improves quality of life, increases societal productivity, and rationalizes healthcare budget. And I hope this did shed some light on this tricky and very intriguing area of kidney genomics. And I thank you for your attention.
Thank you very much, Professor Soliman. It was really wonderful, enlightening about the importance of the genetics and molecular genetics in this part of the renal disease. And really, I enjoyed the case scenarios, which give very nice way of what to do in the differential of patients with FSGS. So we'll go, I would like to ask our audience to put their questions in the Q&A icons. So this is your time to to write the questions that you would like. So the first question here, I can see it. In the genetic factor, if the adult have the same gene, would you suspect it will be the same response as a resistance or response with difference? So if for example, adults have the same genes of the kids, would they behave the same or different?
Well, that's a very good question, because every gene has early presentation or late presentation. Some of the genes have. So if it happens, it probably have the same pathway, but presenting at a different presentation will have a different input. So if you're having a neurological, auditory, and ocular in a child, it's different than when they start to develop in the 4th or 5th decade of life. So it's the same, but its impact on the age where it presents makes all the difference. So if we're having neurological involvement in an infant, this will mean that we'll end up with global developmental delay. So it's the same, and the spectrum of it, it's the same gene, but the spectrum of presentation, the impact on the patient depends very much on the age of presentation.
Excellent. So another question that until what age should genetic testing be proposed to adults? So this is probably from one of our adult colleagues' audience. So we know that if you have a patient with a steroid resistance, nephrotic syndrome, you need to do biopsy plus minus genetic testing, especially if there's FSGS, you need to do genetic testing. So what about if he's adult? Will be the same?
Yeah, another good question. It's not the same as in children, because children have the privilege of having early disease, and in children, early disease and consanguinity are additive factor to ask for genetic testing. But I would probably say, and we do that because I get counsel about adults for the diagnosis all the time, but I would say that it's whether there is extrarenal involvement or family history that would guide the adult nephrologist to go for genetic testing, because this means that it's underlying genetic defect that's probably the reason for these are SRNS, but I won't go for consanguinity, for example. If the parents are consanguineous, I want to genetic testing in an adult because the parents are consanguineous, unlike in a 2-year-old, for example.
Another.
Yeah, I would
Go
like
ahead.
to mention that in IPNA guidelines for steroid-resistant nephrotic syndrome, they put genetics before biopsy. They prefer they recommended both genetics and gene testing and biopsy. However, the preference for genetics for steroid-resistant nephrotic syndrome.
Exactly, but it depends upon the area and everything. But we would have. We would like to think that with the genetic testing, we're avoiding more invasive procedures in the patient. So if you can solve that, that would be great. But again, this, as referred to by Louise earlier in her talk, the inequalities, the availability of genetic testing in different areas. So yes, if we're having the privilege of genetic, I would go for genetics.
Yeah, I totally agree. But biopsy is also important because, as you know,
of course you can do it. But if you sometimes we do genetics, and quite often, you know, our yield in King Abdulaziz 40. The paper with the Fredham is from our center, 45%. But generally we have 40% poster, so you can get the answer in 40%. So it is quite nice.
yeah, absolutely. So probably hands to hands, because using the kidney biopsy in steroid responsive is the indication of doing kidney biopsy in steroid responsive is very narrow list, but it is mainly for steroid resistance. You need to do it. Especially if you find FSTS will be very important for the patient. In addition, of course, the genetic testing, because for a future treatment and if need the biopsy, if need a kidney transplant.
If I might add this, I think one of the reasons IPNA did put genetic testing prior to kidney biopsy is that genetic testing, as you know, the diagnosis, this is an etiological diagnosis. When you get genetic testing positive, this is etiological diagnosis that this genetic defect is causing the SRNS. Whereas if the same patient with SRNS is having FSGS, I'm having a pathological diagnosis, but I don't know what caused this FSGS actually, whether it's non-genetic or genetic or Alport syndrome or IG, you know what I mean? So that's why it was put first, because it's an etiological diagnosis, and this makes the difference between genetic testing and liver and kidney biopsy.
And most of us faced like radio research where the child diagnosed as nephrotic syndrome, and then we found him as phenocopy. There was collagen mutation, and the treatment is completely different.
That's why it's etiological diagnosis.
Yeah.
This is.
So again, here probably you touched the pace about this genetic testing and the importance of genetic testing and those type of patient, and planning of kidney transplantation and kidney transplantation recurrence. Any few words from you, Professor Soliman? Genetic testing and post-kidney transplant.
And that's a very good question, because with genetic testing, we know that the transplant, the recurrence in transplant is far less than the non-genetic. And genetic testing, in this case, we do it for the recipient and for the donor, for proper donor selection.
Excellent, yeah, and the important of the counseling for the parents if the gene is negative, risk of recurrence, unfortunately, 30 to 50%. Yes, Professor Jameela, what you said?
Yeah, just I'm saying what you think about using calcium inhibitor in some of the genetics, because in our area, we usually start calcium inhibitor and we send for genetics. And then if the children partially responded to the calcium inhibitor, IPNA says that you weigh the cost in comparison to the benefit. They didn't give a clear answer. So what we usually in our center try for 3 to 6 months. If there is no response, we just stop. I'm not sure what is your practice.
Yeah, that's a very good point, even though it's beyond the scope of this talk. But yes, we do the same. We look into because calcineurin inhibitors work not as immunosuppressants, they work as cytoskeleton. They work on the cytoskeleton to maintain it. So we tried this for 6 months, as you said, and I think it was a tricky area for IPNA to say whether to do it or not. So it's, I think they left it to each community and each clinical practice area to decide for that. And yes, we do the same as you do.
Thank you very much. Another question by Umar Muhammad. It's an interesting question for the future gene therapy on those type of patients. So he said that given the high prevalence of specific founder mutation in certain population, what about the challenges and the opportunity for developing target gene therapy in nephrotic syndrome?
Yes, that's an excellent question indeed, because you know, the genes and their classifications are based on Human Genome Project, which is where the population, the Human Genome Project, has more than 80% of European ancestry. So we're overlooking an area where genetic diseases are more prevalent. So with more studies, that's why the community, the international community, genomic community for equity for genomic studies, particularly in these parts of the world where consanguinity is high, where we can learn more about these diseases. So the more we work on patients from these areas, the more we understand about them, and the more we get some of the variants that are now classified as variants of uncertain significance, we can actually prove that these are really pathogenic if we can report from these areas of higher consanguinity the same variants with proper genotype, phenotype, because every year they classify these variants, and either the variant of uncertain significance is either goes to likely pathogenic or drops to likely benign. So I think I'm optimistic that with more work from higher consanguinity areas and from populations other than Europeans, we will understand more about SRNS, and it's going as we speak, and will be a room for more targeted therapy, as you said.
Yeah, keeping in mind our webinar is worldwide, so some of the areas with low resources cannot have access, unfortunately, to genetic testing. So keep it in mind in the management of those type of patients. I have a question now from Arwa and from Asma Al-Anizi. They thanks about the presentation, which is excellent. And their question in the basic, they said, what is the difference between whole exome sequences and the whole genome sequences for diagnosis accuracy? And if one of the tests is negative, so what do you prefer to do reanalysis test? Which test you will choose?
Okay, that's a good question. Whole exome is mainly for clinical practice. So for practice, we use gene panels or whole exome. Whole genome, you don't ask for whole genome. This is mainly research. A huge data and interpretation is very difficult. So it's mainly for genome projects and research areas. We've done a recent research of whole genome on SRNS that's submitted currently and has some interesting results. So these are for research, but if you're for practice and you have the means to have a genetic testing, I would say you go for the whole exome. Is the cost is coming down, and the difference between the gene panel and the whole exome in price is not that much, but in information, the whole exome would be more informative. Because it doesn't test only the reported genes, but it tests all the genes that could be responsible for the disease.
Actually, in our practice here in Saudi Arabia, we'll do usually whole exome sequencing. And if the phenotypically is good, and if the whole exome sequences is negative and still the patient have very clear phenotypical of the disease, so we'll send after that the whole genome sequencing, which add little bit yield, probably 10 to 20% extra yield of diagnosing a rare disease.
Because that's excellent, because it's a second tier. It's not a first tier. So it's a second tier, as you said, we go for it. When you don't find in the coding regions of the genome what you're looking for, you look for the other areas and the deep areas that are not covered by a whole exome.
I agree with Neveen. It is very confusing. You have a lot of data with that. But if you examine the child very carefully, phenotypically, you might just like a lot of Shemick syndrome. You go immediately Sanger sequencing, Sanger testing, and then you find, so Neveen concentrated on examining the child and describe him phenotypically. You might save money because you just do Sanger sequencing and that is a gene, smart.
But what about, Prof, if you went for Sanger sequencing for specific mutation, but if you have a novel mutation, you will get stuck. Your Sanger will be negative.
Of course,
so,
of course.
Yeah.
I'm
So
saying
what
if the
we
child
are using, yeah, for me probably what I use Sanger sequences once for the family screening. So once I know the gene mutation in the child by whole exome, I will do Sanger sequencing for the same family because most likely they will have the same gene mutation. I think
whole exome sequencing, but if you are economically under sort of limited,
resources,
examine carefully. If there is signs of syndrome, you might just go to Sanger.
I think I'm seeing lots of questions, but I think we are almost over the time, so we are past the time. So I would like to thank again Professor Neveen Soliman for her wonderful talk and discussions, and thanks for all the speaker, Louise and Bandria. Amr Hussein, I would like really thank you for arranging all this work. So once again, I will before I hand over to Professor Jameela Kari for closing the remarks. So I will encourage the colleagues to register in the Pediatric Nephrology Fellowship, which will be launched, inshallah, next year. And hopefully you will get a lot of benefit from it and easy access knowledge and very wonderful platforms. So thank you very much for World Kidney Academy for arranging all of this. The mic is yours, Professor Jameela.
Thank you very much, Prof. Khalid. Actually, again, I thank all of you, particularly Prof. Amr El-Husseini, for doing all this effort and for organizing this nice webinar. We had a very important subject in childhood pediatric nephrology and pediatric nephrology about steroid-resistant nephrotic syndrome, which is the second commonest cause of chronic kidney disease in children. And we have two parts. The first part was by Louise Oni from Liverpool and London in the UK, and she talked about the type which is caused by circulating factors of antibodies against the nephrin, where there is a place for immunosuppression. And she reminded us that the best treatment is calcineurin inhibitor in form of cyclosporin and tacrolimus. And she showed us studies showing that the success rate is around 40%. Actually, if you select your patients, might be higher even if you exclude those with genetics from early on. She also mentioned about add-on therapy in form of MMF and rituximab. And then for those with multi-drug resistance, there is a new therapies such as the blinatumomab and using plasma exchange, particularly those with recurrence after transplantation with FSGS. And then we have the second part, which was very interesting by Prof. Neveen Soliman. And she talked to us about the importance of genetics, where all of us in our area know how much it is important, and about that it is particularly indicated if the child is young age, or if there is phenotypical manifestation indicating that it might be syndromatic. And she went with us how we select, is it panel testing or is it whole exome or genome sequencing, and the importance of that in deciding the treatment, the planning future children, and also for the recurrence in transplantation, as this almost does not happen after transplantation. So it was very useful and nice. And again, thank you to all of you, and particularly to Prof. Amr El-Husseini. And actually, again, I tell the fellows that registering in this program, it will empower them with knowledge, and it will make their knowledge in pediatric nephrology very strong, so they can complete it with the clinical fellowship in our centers. But I think it will give them a lot of knowledge and and they will make them more competent clinically as well. Thank you.
Thank you so much, Professor Jameela. And thanks, Professor Khalid, Professor Neveen, Professor Vandrea, everyone. And I think with that, we are closing our webinar today, and we will have every month from now on, we'll have monthly webinar for pediatric nephrology. So please stay tuned, and we are going to send you more information. I saw some questions in the chat box about the registration and application for the fellowship. And I put some links in the chat box if you want to copy and paste it to use it in the future. But I'm also going to email all of you who attended this webinar more information about our fellowship. And of course, in the incoming webinar, we are going to give you more and more information. Again, thank you so much, everyone, for attending and participating in our webinar today. And hopefully we'll see you next month.
And that I'm very happy to see that universal, to see the doctor from Brazil, and it was very nice to see a global group.
Yeah. At least virtually.
Virtually.
Yeah. See you. Bye. Thank you.
Thank you.
See you.
Bye.
Thank you.
Bye.